Welcome to Ask Dr. Mingle, the Q&A series from Mingle Health answering your questions about quality programs and the transition to value-based care. I'm Kyle Breckel. I'm a digital marketing specialist at Mingle Health, and I'll be hosting this episode along with Dr. Dan Mingle, founder and CEO of Mingle Health. Good morning, Dr. Mingle.
Good morning, Kyle, and good day to all of you tuning in. It's great to see you again. I'm Dr. Dan Mingle. I'm here to answer your questions to the best of my ability.
Well, we have three great questions for you today, Dr. Mingle, so let's just jump right into them. First question for you today, Dr. Mingle, is from Michael. And Michael asks, I understand the difference between the MIPS clinical quality measures, which are MIPS CQMs, and electronic clinical quality measures, which are eCQMs, but I'm struggling to understand the reporting requirements. Are you not able to have a mix of the two in your quality submission? I am reading that you have to choose one or the other, but if that is true, does that mean that certain measures in the same specialty set can't be submitted together? For example, like number 155 and number 318 under podiatry. Any feedback you could provide would be greatly appreciated.
Great question, Michael. Most people do make it a choice between eCQMs and MIPS CQMs, but the truth is you can mix and match mechanisms. Now, for a quick review of quality measure mechanisms, for those of you unfamiliar with the jargon, under Medicare's quality payment program, first, MIPS clinical quality measures, that's MIPS CQMs, are submitted to Medicare by a qualified registry. Qualified registries have complete freedom to retrieve data anywhere it exists, even combining data sources to create what is generally the most accurate analysis. Your organization could qualify as a registry if you go through the steps defined by CMS. Electronic clinical quality measures, that is eCQMs, are typically generated by an electronic health record software. There are third-party vendors that also create and submit eCQMs. Every step in the eCQM chain of data storage, data recovery, and analysis has to be certified by standards set by the Office of the National Coordinator of Healthcare Information Technology. That's the ONC. There are also Medicare Part B claims measures that involve adding a quality data code, that's a QDC code, to patient claims sent to Medicare. This mechanism has typically been the least reliable, and today it's permitted only for use by small practices. Qualified clinical data registries, that's QCDR measures, are generally built, tested, and maintained by a third party and approved annually by Medicare. These generally are topic-specific to the third party and are often specialty-specific. Many specialty societies operate QCDRs. Now, with those in mind, any practice can submit duplicate measures, more measures than needed, measures from multiple mechanisms, and measures from multiple vendor sources. Now, whether these scores come from one or multiple mechanisms, one or multiple vendors, Medicare intends to follow the following three rules. One, when a measure is submitted in duplicate from the same vendor using the same mechanism, the most recent submission overwrites prior submissions. When duplicate measures are submitted by multiple vendors or multiple mechanisms, Medicare grants the best score received. When excess measures are submitted, Medicare counts the 6 best scoring measures, or whatever your submission requirement is. So that's generally the rules. I say that Medicare intends to follow these three rules because they sometimes get it wrong, and then you need to call them on it during their focused review period. So thanks. Great question, Michael.
Yeah, thank you, Michael. And our next question for you today, Dr. Mingle, came in a YouTube comment from Arnaud. Arnaud says, thanks a lot for your great summary video of Primary Care First, PCF. The question is billing and payment for non-primary care affected? For example, would radiology services still be paid under traditional fee-for-service? And if so, are there any fee-for-service payment adjustments linked to quality performance measures?
Great question, Arnaud. There are 3 buckets of payment. That's 3 buckets of payment in the Primary Care First program. First, there's a monthly prospective care management fee paid for attributed patients. Second, there's a flat visit fee for all visits that are within the primary care list of visit codes. Medicare annually updates and publishes this list. It includes the usual E&M codes and care management codes and others. Fee for service is paid for any services provided that are not in the list of primary care codes. Payment is made consistent with the annually updated physician fee schedule, and that goes for office procedures, radiology, lab, anything that's not on the primary care code list. Any quality adjustments earned by the PCF practice are applied to the monthly prospective payment and the flat visit fee, but do not affect payment for the non-primary care services and charges that are paid through the physician fee schedule. Great question, Arnaud. Thanks.
And our final question for you today, Dr. Mingle, is from Tom, and it has a lot of important context to understand before we get to the actual question. So Tom says, we have a physician in our ACO who only provides telephonic on-demand services. He has referred patients from a clinically oriented website and provides these telephonic services mostly for urgent care type problems. He bills telehealth codes 99441, 99442, and 99443. Based on his exclusive use of the 99441, 99442, and 99443 CPT codes, he has no liability for two of the three APM performance pathway quality measures. And those two quality measures are hemoglobin A1C control and blood pressure control. But his billing codes are included in the eligible codes for the depression screening and management measure, which is number 134. As you can imagine, patients calling in for an acute or chronic arthritic complaint may not be in the right mindset to answer a question about their mood while experiencing pain. It also would not be appropriate for this doctor, after interacting with the patient a single time, to recommend a treatment plan, especially since he has no means to follow up with these patients or familiarity with the available resources in their area. So we're wondering if an extreme and unusual circumstances, which is an EUC application, might be applicable here.
Great question, Tom. An intriguing practice, filling a useful niche. But I wonder if it's a practice that you want to maintain in your ACO. Does it provide enough value to ACO-attributed patients to be worth your administrative time and the risk to your ACO quality scores? You're absolutely correct about the diabetes and hypertension control measures in the APP measure sets. That's the APM performance pathway. The three codes your doctor bills are not in the measure specifications, so your doctor will have no eligible instances for either measure 1 or 236, that's hemoglobin A1C or the blood pressure control measures. But 99441, 99442, and 99443 are in the specifications for the depression screening measure, number 134. So all of his patients will have eligibility for that measure. Now you can try an EUC. Our staff provides assistance and or guidance to our clients with their EUC applications. I'm a little doubtful that Medicare will reliably, year after year, approve that application. It is somewhat case related. People who approve those applications are not usually the most senior people at the help desk. So you may find some difference from reviewer to reviewer what is accepted and what's not. And circumstances change. Medicare may be 1 year more strict in 1 year and the next year less. And my patients are too focused on their pain to be willing to answer questions about depression argument can be made from most even in-person provider-patient interactions. I'm inclined to think that patients in this setting might be at particularly high or at least worrisome level of risks. Patients who are avoiding in-person evaluation might be at greater risk of having their signs and symptoms of depression missed. It may be especially valuable to include simple screening in these encounters. My suggestion is that a simple screen be included in the pre-visit assessment. With this online connection, there must be a series of questions, written responses, lists that patients are responding to, and it would be a fairly simple matter to include a screening question or multiple questions in that list. There's great evidence that patients are more open to answering sensitive questions on a form than they are verbally when face-to-face with the providers. Or perhaps it's that providers are more inclined to include it in a routine form than in their own list of questions. And management doesn't have to be definitive. Referral to a hotline number or to the patient's primary care provider can suffice. So tough decision all told, but I think there is a way to navigate through it. Thanks for the great question, Tom.
Yeah, thank you, Tom, and thank you to Arnaud and Michael as well for the excellent questions today. And thank you, Dr. Mingle, for sharing your insight with us today.
Thank you, Kyle, and thanks to Arnaud, Michael, and Tom for the great questions. I want to be helpful. I want this to be useful to you. Don't hesitate to correct or supplement my answers. Share your experience. Ask your questions. We can be smarter together.